So let's talk about dialysis. So dialysis is the process. Let me go. Yes, so dialysis is the process that we put patients on when they get to end-stage renal disease, and not we as the nurse, but the doctor puts the patient on dialysis when they get to the point where their kidneys are not functioning at all. They're not filtering enough to where they're going to be building up so much waste that they can have unsafe levels of potassium. They can also have such high waste to the point where they can't even barely stay awake because there's so much waste in their body. But it gets to the point where their body just cannot manage that by itself. So dialysis is the process of an external machine actually serving as the function of the kidney. It filters the blood and it gets rid of those wastes. It stabilizes your electrolytes and it removes fluid. It does all those, some of those, not all of those, but a lot of extra jobs of the kidneys while the kidneys are not functioning. It can be used for kidney failure patients. It's also used to treat overdoses. Like there's some overdoses like antifreeze overdoses and things like that, that the only way that we're going to fully get that toxin out of our system is through a dialysis treatment. Most of the time, and for the purposes of this class, you're really focusing on those patients in kidney failure. And there's two options. There's what's called peritoneal dialysis and hemodialysis, and we're going to break down each of those. So who gets dialysis? Like I talked about in my chronic kidney disease PowerPoint, patients with a glomerular filtration rate less than 15, and then also certain conditions can sometimes require temporary or permanent dialysis. So patients that are incredibly volume overloaded, patients that have refractory hypertension, patients with very, very high potassium to the point nothing we're doing is getting it down. Patients that have what's called uremic pericarditis, which sounds like really fun because it's cardiac related, right? But when you have a buildup of waste that leads to pericarditis, a lot of times we need to, what do you call it? The only way we're going to get those wastes off is through the dialysis. Drug overdoses, like I mentioned. And then also, if you're getting to the point, like I mentioned again, where you have so much waste buildup that you're going into a coma, or you've lost your ability to function neurologically, that would be another reason. So let's talk about peritoneal dialysis. Peritoneal dialysis is a daily dialysis. So this is something you can do at home. The benefits of it is that it can be initiated immediately. It doesn't take as much preparation work. It's less complicated. Like I mentioned, it can be done at home. And it's good for patients that have vascular access issues. So we're going to kind of talk about this, but patients that get hemodialysis need to have a vascular access, so something in their blood vessels. And if you remember, a lot of stuff we've been talking about with kidney disease is it's a blood vessel issue. A lot of these patients have hypertension, diabetes, which have horrible issues with blood vessels. So a lot of these patients, maybe they try to do hemodialysis, but they couldn't get any access because their blood vessels are tortuous, full of plaques, having a lot of issues. So this is a great option for patients that they maybe tried something else and it's just not, they don't have the right supply, aka good blood vessels and things that they need to give the other types of dialysis. The disadvantages, of course, is there's a high risk of peritonitis, not a high risk, but I would say that there's a moderate risk of peritonitis, that's definitely something life or death, and we want to avoid that. There's also a lot of protein loss with peritoneal dialysis, so we have to monitor that closely. There's a greater risk of infection. There's a risk of infection in both, but there's a good risk of infection because, especially since patients are doing this at home, having to have that strict aseptic technique, they have a higher chance, because of the way that peritoneal dialysis is done, to have high blood glucose because of the solution that they use to get dialysis. That also requires the patient, which, remember, these patients are tired, weak, sometimes confused, or a family member, to have the physical ability to manage this, and they have to be able to be educated. And then after about 2 years of using peritoneal dialysis, the mortality rates increase. So it's kind of good early on, but as time goes on, it becomes less safe. So how do we give peritoneal dialysis? We always have to start with access. And so access for peritoneal dialysis, because peritoneal is in your abdomen. So there's a catheter. It probably looks almost like a feeding tube, but it's actually a peritoneal dialysis catheter. It's in your abdominal wall. And the tip of the catheter is in your peritoneal cavity. It's usually placed surgically, and it takes about 2 weeks for healing and sealing of that insertion. I said that, making sure I was saying that right. Healing and sealing of that insertion site. And these can be used immediately, which is a great benefit for someone who needs it right away. So there's 3 cycles effectively. So there's this catheter that's in, that peritoneal cavity. What happens is that you, in that, you kind of literally hang, like, or not hang, but you infuse a bag of fluid. You do a fill period where you infuse a bag of fluid through that catheter into your peritoneal cavity. It's usually about 2 liters of fluid. That's a lot of fluid. We're going to talk about that. And it usually takes about 10 minutes to fill. Then you have a dwell period, and this is where the diffusion osmosis occurs. I'm not going to go in depth about exactly how dialysis works. I'm sure you'll learn a little bit in class, but effectively what happens is whatever that dialysate fluid is, it's usually a very concentrated bag of fluids, and it's trying to, it's trying to get your body to assimilate more to like whatever it has too much of, it's trying to help get off. So it's going to help get off your electrolytes, remove that waste because of the different forces like diffusion, osmosis, and things like that as well. And so effectively what happens is it pulls off fluid, it pulls off particles and things that are based, that are building up. That's the word I'm looking for. And it helps to take them out of the abdomen. So all that fluid that's dwelling in the abdomen, it is literally working to get rid of all the things that are building up that are not working in your body. A patient can have a dwell period of like 20 to 30 minutes, or they can walk around with it. They could be walking around with this 2 liters in their abdomen for 8 hours, and pretty much just allowing it to have a longer dwell period and really soak up all that stuff that's trying to get out, those wastes that are building up in their body. Then there's a drain period, and takes about 15 to 30 minutes, and they may need to gently massage or change positions to help to get all that fluid out of their abdomen. So there's obviously a lot of complications possible with this. Of course, there's infection. You have a catheter in your belly, which is not the most sterile place, and it's not in your belly, but it's in your peritoneal cavity, in that space in between. And because this catheter is not me, it's always going to be a risk for infection. There's an easy place for entrance of infection from outside, and because, like I mentioned, the location of that catheter. If they have an infection, they're going to have symptoms like redness at the catheter site, tenderness, drainage, and then once it progresses to peritonitis, if you remember back from adult, abdominal pain, severe, sharp, sudden pain, rebound tenderness, which means when you push down and when it hurts when you let go after pushing back down. The stuff that's coming out of them when they're draining after they've dwelled, it's going to be purulent, cloudy, look like there's infection present. They can also have abdominal distension. We can prevent this through a good aseptic technique and doing very good teaching with them. We also want to minimize the amount of connections and disconnections. So we want to try to keep them continuously connected while they're there. We don't want to keep taking it on, taking it off. We also want to treat them if they have an infection, treat their antibiotics. And, if it comes down to it, they may need removal of the catheter or switching out of the catheter if it becomes infected. There's also complications of bleeding and protein loss. Bleeding because of where the catheter is placed. The peritoneal membrane is very sensitive. It has a lot of little tiny blood vessels on it. And so as a whole, it can get very easily irritated, especially with that dialysate fluid. So we want to watch closely for any bleeding. And then protein loss, because this process is happening in the abdomen, and that peritoneal membrane is very permeable to allowing for proteins to switch over and get removed. So you have a higher chance of losing proteins through this type of dialysis. So, of course, the clinical manifestations of a patient's bleeding, you're going to see blood in that drainage that comes out of them when they're draining their abdomen. And then with the protein loss, you're going to see that they're going to be more fatigued. They can have muscle wasting. They might be also getting infections more often. We can prevent these, we can prevent bleeding. And so we can wait a period of time before we start peritoneal dialysis, which means I need to try to, if I have a patient that is showing signs that they're going to need dialysis soon, I need to make sure to be staying up with the doctor, get that catheter placed earlier so it has time to fully close and heal, so there's less chance of irritation at that site. And then for protein loss, I want to minimize their risk of peritonitis. Anytime there's inflammation in the abdomen, or kind of like all the things we just talked about for the to decrease the risk of infection and peritonitis. If they have peritonitis, they're going to lose so many more proteins because their peritoneum is going to be all irritated, and it's going to have a higher chance of losing protein. So I want to minimize their risk of peritonitis, and then I also want to increase their protein intake. So when we talked about a diet for a patient on peritoneal dialysis, we talked about them needing to have maybe a moderate protein intake. Treatment as a whole, if they're bleeding, they may need blood replacement. We're going to monitor their hemodynamics closely. And they may need further evaluation, just depending on the cause, make sure there's no infection or something else going on. And then for protein loss, we're going to do a higher protein diet. Like usually we say like a moderate protein. We usually don't do high protein in kidney disease, but we do a moderate protein diet. And then again, preventing the infection and peritonitis. So additional complications from peritoneal peritoneal dialysis is they can have hernias, lower back problems, and pulmonary complications. So remember I told you these people are carrying around 2 liters of fluid in their belly. And even if it's for a short period of time, it's too much pressure in the abdominal area from all that extra fluid. There's it's either literally extra weight you're carrying around, which creates extra pressure, or the pulmonary complications. It's all this extra fluid. It's going to push your lungs up where they can't expand the way that they need to. So, these patients, of course, the hernia is going to depend on the location, but if you remember what a hernia looks like, it's kind of an outpouching. If you have it in your belly button or something like that, it can be that outpouching, and especially when they're, coughing, you'll kind of notice it, like you'll see that extra, protrusion of tissue. They may complain of low back pain. And then for their respiratory symptoms, they can have shortness of breath, use of accessory muscles like general dyspnea, or they could even have signs and symptoms of respiratory infections. We can prevent this by having shorter dwell times. So in other words, the less amount of time that they have to carry around that fluid in their abdomen, the less chance they're going to have of having those back pains, of having those pulmonary complications, getting a hernia. We want them to lose weight if possible, because that can help to decrease some of that intra-abdominal pressure that's causing an issue. Regular exercise is going to be key for these patients, and appropriate positioning. Head of bed elevated to help support their breathing. As a whole, the treatment, like I mentioned, we're going to decrease their dwell times, elevate their head of bed. If they get infection, we're going to give them antibiotics. We might do a hernia repair if they get one. We can wear orthopedic binders to support their back, and deep breathing exercises can help as well. So we've gone through peritoneal dialysis. So let's talk about hemodialysis. This is much more commonly used. This is the dialysis that's given 3 days a week, or 3 times a week. It's usually either Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. The advantages of this, it's rapid fluid removal. So it's not over time, it happens quickly. It rapidly removes the waste and potassium. There's less protein loss. And there's availability to do this quickly. So if the patient needs this emergently, we can get in a temporary access for them. The disadvantage is that there's vascular access issues. In other words, like we talked about before, some patients, they just don't have the blood vessels they need in order to get the access they need to do hemodialysis. Their blood vessels will not comply. There's more dietary and fluid restrictions. The equipment is much more extensive and expensive. There is a higher risk, because there's big fluid shifts, of having low blood pressure or hemodynamic instability with this. There's also blood loss, which can make anemia worse, that they already have in their chronic kidney disease. You need to have a specialized trained person, and they also may need to be heparinized, and they may be at higher risk for blood clots and things like that through this process. So hemodialysis access, this is one of the biggest challenges. And like we mentioned, these patients already have usually cardiovascular disease, poor vasculature, they may have diabetes. And so they have a lot of things working against them. They need to create a large blood vessel that's able to withstand a lot of pressure. Because effectively what you're doing here, when we talked about peritoneal dialysis, they're putting some fluid in and those fluid shifts are happening. What this is doing is this literally pulls your blood out. It's sucking it out, cleaning it, filtering it, getting that fluid off, and then it's putting it back in, after it's done. And so I need a large blood vessel able to withstand a lot of pressure. So my 3 options for hemodialysis access is 1, what's called a fistula. And this is where you actually bring together 2 of your own blood vessels. This is what is the preferred access. It's preferred because it's your own blood vessels, so there's less chance of infection. And these usually work very well if they have the vasculature that will accommodate for this. The only downside is that it takes about 6 weeks to months to mature for it to use. So this is not something that if they really need it emergently, we can use right away. There's also what's called a graft. So some patients, they may not have the vasculature that they need. What we can do is instead of, fusing together their artery and their vein to create that high pressure vessel, they actually use a synthetic like tubing in between an artery and a vein in your arm. And we call it, that's going to create that high pressure system we're looking for, without, putting your blood vessels together if they just won't, if it doesn't work like out, because sometimes they can't get the blood vessels to fuse together. So while that may seem like a great fix, you're putting something in you that's not you. So that plastic device is going to create a higher chance of infection. It only takes about 2 to 4 weeks to heal, but again, there's that higher risk of infection. And then the last option would be a catheter, like an almost like a central line. It's put usually here in this right upper chest. It's called a perm cath. It's inserted in your large blood vessel, and it usually is only used temporarily. But some patients, they've tried every access, every blood vessel we could possibly use, and there's no other option. So this is the only choice that they have. So here's kind of an example of a perm cath, how it goes right in there, right into the heart. Here's a picture of a graft, and here's kind of a picture of a fistula, how it all comes together, kind of just to see the difference between those. So let's talk about complications. So just as with peritoneal dialysis, there are complications, there's also complications in hemodialysis. So first and foremost, we're diverting and doing stuff with the blood vessels. We're putting two things together, we're putting the artery and the vein together. So there's what's called arterial steal syndrome. And this is literally blood is stolen from the hand. So we need to do a very good peripheral vascular assessment on whatever side that they have the fistula graft on. And so the signs and symptoms of arterial steal syndrome is that there's going to be pain distal to their access site. They might have some numbness or tingling, like kind of a feeling like their extremities falling asleep. And they're also going to have poor capillary refill. And so we want to be looking for those closely. They also can have aneurysm, rupture, blood clot formation, infection of these sites as well. When patients have these hemodialysis access, these fistulas or grafts on whatever arm they have them on, we're not going to do a blood pressure on that arm. They already have this weird vasculature that we've created. And if we do a blood pressure on that arm, it can actually completely ruin that access. So no blood pressures, no IVs on that side, whether above or below, it doesn't matter. We're not going to put any IVs on that arm. And no sticks on that side either. So they should have a special band that says, do not use this arm. We also need to do a really good assessment of their dialysis access. And so we're going to listen and feel their dialysis access. So we are going to feel for what's called a thrill. And that's like when, sometimes they're up here in the arm or sometimes they're lower, but I'm going to put my hands on feel, kind of like feeling for a pulse. And it should be a buzzing vibratory feeling that I feel that. Remember, it's a high pressure system. So you should be able to feel kind of this buzzing vibration underneath your fingers. It's something when it's working right, it's undeniable. It's not something you have to search for. You know how it's always so hard and you're embarrassed when you're at clinical and you're trying to figure out where the heck are the pulses? This is not one that's usually hard to find when it's working. There's also what's called a bruit, and that's something I listen to. So I actually put my stethoscope in the same place I was just feeling, and I listen. I should hear, it should sound almost like a murmur. It's like whoosh, 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 because it's a high pressure system. So that's what I'm going to be doing to assess for a fistular graft. So doing hemodialysis, some things to consider. I need, large gauge needles. We call it dialysate solution and a dialysis machine and a lot more. Now as a nurse, unless I'm a dialysis nurse, I'm not setting all this up. They're going to bring all this equipment. They are going to know how to get all this set up. I watch them sometimes and I'm amazed at how they figure out how to set up this machine because it looks very complex to me. Prior to the hemodialysis, we're going to weigh the patient. We're going to assess their vital signs, especially their blood pressure. We're going to assess their fluid volume status and see as a whole how they're doing because we want to see, is this treatment effective? How are they before and after? Regardless of how much fluid they take off, how is the patient afterward? If their lung sounds are wet, if they're full of edema, how does it seem afterward? If their weight was this before, how much was it afterward? And how are they feeling after? What's the difference in the patient's symptoms? So like I mentioned, dialysis is done 3 times a week, 3 days a week. And it takes about 3 to 4 hours for each treatment. It's rapid, but it still just takes some time. That's a long period of time to have to commit. It's almost like a part-time job. So some of the major complications that can happen, aside from the vascular access complications, one of the most common things is hypotension. So hemodialysis, I said hemodynamics because I got so excited because I saw the screen. Hemodialysis involves a rapid fluid removal, and that rapid fluid removal can lead to hypovolemia. We have to do frequent pressure checks. Sometimes we check them every 5 minutes, or even more frequently than that, because they can have rapid changes. If they do have drops, sometimes the patient needs fluid or albumin. I know that kind of seems counterintuitive. Aren't we pulling off fluid? But sometimes it drops so low. These patients can be really sensitive. And then also muscle cramps because of the fluid and the electrolyte shifts and things like that. A lot of times they can have really bad muscle cramps, especially in their legs. So if that happens, the dialysis nurse can reduce the pool of the fluid, stop pulling so much because maybe the patient's not tolerating it. Or they can also infuse some glucose or hypertonic saline, just small amounts, just to kind of help, and that sometimes can decrease those muscle cramps. There's also the risk of anemia because there's blood loss during the dialysis procedure, because literally part of their blood system is getting filtered through this machine, and we return as much blood as we can, but there's always going to be some blood loss. And this patient already has anemia, most likely with their chronic kidney disease. They also have frequent blood draws with dialysis, so they're losing more blood in that process too. We want to try to ensure that we can give them back as much blood as we can from the machine. They may need regular erythropoietin and blood replacement with their dialysis treatments. Even though the blood is, these machines are cleaned down and taken care of, and they use different tubing for different patients, there also is the risk of hepatitis with these machines. And yes, it still happens sometimes. A lot of these patients that have kidney disease also have liver disease and other issues. So we just have to keep a close eye and make sure we're keeping aseptic technique, cleaning things down as possible. A lot of patients that get dialysis are going to get the hepatitis B vaccine, and we're going to follow very, very strict protocols. They may need hepatitis treatment if they end up getting hepatitis. So when things get complicated, so as much as I was sitting here and saying like, oh yeah, running a dialysis machine is really complicated, I don't know how nurses do it. I have many times, and it's one of actually my favorite things to do in the ICU, is run what's called CRRT, and that's what's called continuous renal replacement therapy. So this is me as an ICU nurse. I can get trained to use this device. And doesn't this look exciting? Look how many medications are going, and all this tubes and lines. Like, this is my dream as an ICU nurse. It's complicated, but it's a numbers game, and this is the only type of math I ever like to do. But anyway, effectively what this is most patients, like I mentioned, with regular dialysis, we're doing a rapid removal of that fluid and everything like that. Well, like I said, some patients don't tolerate it. Their blood pressure is already low, or they're having issues. Maybe they have an infection. Maybe they're in shock. Something's going on. So what continuous renal replacement therapy is, instead of 3 times a week, rapidly pulling off that fluid and those electrolytes, I'm going to do a continuous 24 hours a day dialysis. It's a gentle pulling, gentle taking off of the waste. And so it's a 24 hours a day, like a continuous dialysis. And these are for patients that are hemodynamically unstable, that are like on vasopressors, like norepinephrine, epinephrine, vasopressin, etc. And those that won't tolerate the traditional hemodialysis. We usually use a dialysis catheter. I can't access a fistula or graft. I'm not a dialysis nurse, so they have to have the catheter, the perm cath, or a central line. And not a central line, they have to have a special dialysis catheter. Yeah, they have to have a special access for that. They have to be specially trained to operate this machine. I have to change the filter out every 24 to 48 hours. I'm going to be monitoring all their hemodynamics, their labs. I'm doing frequent assessments. This is a one-on-one patient. Like, this is my only patient when I have this patient, because they require all of my care. I'm managing this machine. I'm managing all their medications. I'm taking care of them. They're very, very complicated, but also it's like I said, one of my favorite things to do, because it takes a lot of maintenance, and every hour you have to figure out, okay, what's going in them? How much fluid do I need to pull? But, I find it to be one of the most challenging, but, interesting things for me to do. So it's just another way that we can help our patients if they don't tolerate, they need dialysis, but they just don't tolerate that rapid dialysis. So anyway, now that we've nerded out on dialysis, hopefully this makes sense, and you've broken down more some of those differences between hemodialysis, peritoneal dialysis. It's all about complications. So it's about knowing, like, what's going to help this patient. What do I need to be assessing for or watching for? What risks are there with each of these dialysis? So anyway, hope this was helpful. I'll see you next time.